shall go live now. Okay,
but
so this meeting is already.
Otherwise, you guys won't be seen. Should I stop sharing?
So, no, sir. You can start sharing. You can continue sharing this.
Oh, yes, sir. We are live now.
We are getting now.
Okay. So, good. Sasi sir, can you
I think we're online, right?
Yes, sir. We are online, sir.
Okay. Share, sir, if you can stop sharing, then we can have a very short introduction, and then
yeah, there you go.
We can share again.
Perfect. Yeah.
Okay. So.
Okay.
Yes, sir. So,
okay. Shall we go ahead, Soumya?
Yes, sir. Yes, sir. Yes, sir.
Yeah. Good day, everyone. Welcome to another show and another day of education from the Indian Cartilage Society series of webinars. Today we have a learned and experienced senior consultant, that is Dr. Shreyas Gajja, who will be talking about his algorithm for cartilage reconstruction of the knee. And we also have Dr. Jyoti Prashant with us, who is going to share an interesting case of cartilage reconstruction subsequently. I would now request the organizers, Dr. Soumya Agarwal and Dr. Karthik, to take over and introduce Dr. Shreyas to proceed with the webinar. Over to Dr. Soumya.
Good evening, everyone. So again, as we continue with our ICS monthly webinar, here I am introducing Dr. Shreyas Gajjar, who is an eminent arthroscopy and sports orthopedic surgeon, and he is working currently at Kokilaben Dhirubhai Ambani Hospital in Mumbai. And so today his topic for this talk is his algorithm for cartilage repair. And sir, over to you. Please share the slides.
Yeah, okay. Can you see my slides, guys? Can you see my slide?
Yes.
Okay.
So there is something.
There's one more screen over that, sir.
Right, 1 second. How's that?
Yes, perfect.
Okay. Good evening, everyone, and thank you very much, Rajat and the ICS team for the invitation. My topic is my algorithm for cartilage repair of the knee. As mentioned, I work in Kokilaben Dhirubhai Ambani Hospital in Mumbai. So we all know that cartilage injury remains a challenge, and following the early stages when there is damage to the chondrocytes, there are several cellular and metabolic changes which lead to increased tissue hydration and fibrillation, disorganization of the collagen, which causes an easier transmission of impact loads to the already damaged cartilage, and that results from in a spectrum of progression from partial thickness to full thickness defects, as you can see there. Also, these full thickness injuries would subsequently involve the subchondral bone, and what would happen is a regeneration of type 1 collagen, which, as we all know, would be unable to operate in this high stressful loading environment, and that would lead to further cartilage degeneration or damage, and thereby progression of osteoarthritis, as seen here. So, any form of also malalignment would increase the contact pressures in the knee. Any previous partial or total meniscectomies would significantly increase the contact pressures, leading to as high as 6.5% volumetric loss of cartilage per year.
Sir, your slide has not changed. Sir, your first slide. You're on the first slide.
Oh, okay. I don't know how I can see the slide change. Okay, 1 sec. Let me just go back.
Slides are not changing.
Now, can you see the second slide?
No, sir.
Okay, I'll stop sharing and start again. 1 second. Can you see my presentation now?
Yes, we can see the first slide,
Yeah.
so introduction slide.
Yeah, let me just see if I can. Now, can you see
Ah,
the
yes, sir. Now we can see the. Yes,
second?
yes, sir. Now it is there. Second slide.
A technical glitch. So, cartilage injury, as I mentioned, remains a challenge. And with early stages of chondrocyte injury, there are significant cellular and metabolic changes which lead to increase, tissue hydration and thereby causing disorganization of the collagen. And what that results is an easier transmission of impact loads to the already damaged cartilage, and a partial thickness damage would gradually and progressively lead to a full thickness defect, as it's seen in this arthroscopic image at the bottom right. Also, the full thickness injuries that penetrate the subchondral bone would cause regeneration of type 1 collagen, which, as we all know, would be unable to operate in the high stress environment, causing further cartilage degeneration and progression of osteoarthritis. And you can see these radiographs here where there is end stage osteoarthritis. Now, the presence of malalignment would increase contact pressures in the knee. Any previous partial or total meniscectomies would increase contact pressure as high as 6.5% volumetric loss of cartilage per year, leading to progression of osteoarthritis. Also, any delay in the management of ligamentous injuries would cause, in the presence of poor meniscal and cartilage environment, would lead to rapid deterioration. So, any form of cartilage injury at the time of this ligament or meniscal surgeries should be addressed in whatever form it needs to be. And, in the algorithm, cartilage comes later on, but, its alignment, its ligament balance, the meniscus, restoration, and cartilage would be the last option. So when I approach patients with cartilage issues, I inquire whether, from their etiology, whether it's a traumatic or a chronic repetitive type of an overload. I would look for, symptoms either in isolation, be it pain, swelling, stiffness, locking or catching, or in combination. And I would also, if they have investigations or if I order one because of their symptoms, whether these cartilage related lesions are incidental on MRI, or if I'm doing some sort of a ligament surgery, whether it's an incidental finding on arthroscopy. I would investigate them in terms of imaging, especially if there is a traumatic etiology or if they are in the middle age group, for plain radiographs where a traumatic event would identify a loose body, as you can see here, lying in the suprapatellar area originating from the medial femoral condyle defect. MRI remains a mainstay investigation wherein we can determine the depth, size, location of the lesion, and importantly, whether or not the subchondral bone is involved, because this would influence our management. Now, when it comes to decision making, when I see these patients, I would then correlate the relevance of the cartilage lesion to the patient's symptoms, and where it is an incidental or a degenerative type of a cartilage change, I would initially opt for a trial of non-operative treatment. And also, the type of etiology, whether it's an incidental trauma or whether it's a significant trauma or a focal degenerative or generalized arthritis, which would influence my decision making whether I should opt for non-operative line of treatment. But the golden rules for patients who would qualify for surgical intervention would be that failure to respond to non-surgical intervention, which is predominantly medications, physiotherapy, the presence of persistent pain, swelling, functional limitation, the presence of cartilage lesion, predominantly a focal, chondral or an osteochondral lesion. And when I advise them or kind of counsel them for surgery, I would give them realistic expectations depending on the extent of the lesion, depending on the expectations in terms of return to the level of activity. Also, I would counsel them regarding the length of recovery, that these would take at least 6 to 12 months depending on the size and the depth of the lesion, and that they have to comply with rehab. They need to be patient because that would determine the ultimate success of the procedures. And also, I would be wary of certain cofactors in terms of the activity level, or things like smoking, high BMI, and the elderly group, because we know that the quality of the cartilage is weaker with increasing age. And as I mentioned earlier, it's important to address all the concomitant pathologies so that our cartilage repair surgery would succeed. So when it comes to surgical options, my mainstay for incidental or very small kind of fibrillations or grade 2 or 3 lesions would be debridement, wherein I'm trying to stabilize the loose flap which causes mechanical symptoms or effusion, and I aim to restore the stable edge, as you can see on the arthroscopic image on the right. And the best way to kind of achieve a stable edge is to just start the suction and not to actually get the tip of the burr or the body of the burr to touch the cartilage, but bring it very close, and you can nicely shave off the fibrillations to get a smooth area. My goal is to alleviate mechanical symptoms and irritation, and thereby balancing the lesion to prevent its propagation, and also from any mechanical stress of any unstable flap. As we are aware that debridement or chondroplasty has the advantage of early weight bearing. Also, it has a shorter period of recovery, and it's a quick, inexpensive procedure. But we need to be aware that when we stabilize this, the congruency of the condyles, for example, or the patellar, medial or lateral facet is not restored. So we need to keep that in mind. When I have a traumatic osteochondral lesion, the best thing is to fix it, and we have various options, biodegradable to metal pins. You can see this arthroscopic image on the right, where I have used 2 screws. Now, one can use the biodegradable screws or these headless screws, but it's very important that we aim to restore the original cartilage. So the earlier you advise surgery and identify these patients, it's better. We need to make sure that these fixation devices are flush or slightly buried into the beyond the cartilage level, because you don't want them to cause any abrasion or friction. And when it comes to broadly, the other forms of options for cartilage treatment, I tend to divide them, the defects I see in my practice, into small, medium, or large. And then I would look for whether it's a osteochondral or a chondral lesion. So if it's a small lesion, I would look for micro drilling. Microfracture is no longer recommended because it causes a subchondral fracture, which leads to a poor regenerate fibrocartilage. If it's a solitary lesion which is osteochondral, I'd go for the Oates procedure. When it comes to medium to large size defects, I am looking for some sort of a cell based treatment, because we want to try and get hyaline like tissue. Now, bone marrow stimulation is a quick procedure for smaller defects. It is minimally invasive. It has a shorter recovery time. But the unfortunate thing is that it replaces the non-hyaline tissue by fibrocartilage. And we have evidence of good results in the midterm, but as the outcomes go beyond 5 years, the quality of tissue degenerates, becomes poor. So we need to be aware for it. And as I mentioned, in the modern day, we want to do micro drilling rather than microfracture. When it comes to solitary defects involving the osteochondral area, I prefer the Oates system. It's a one-stage procedure, involves a shorter recovery time. However, more than 2 defects can be challenging, because the between the 2 plugs you will get fibrocartilage, and also you can't replicate the contour. So you got to be really good at doing your procedure. And I will not hesitate in doing a mini open if I can't approach perpendicular to the defect, and if I am dealing with 2 or more osteochondral plugs. So we need to get the contour of the condyles as much as possible, and try and avoid more than 2 plugs, because it has been shown to compromise function in the long term. And there are various studies, 15 to 7 year randomized study as this one published in the AJSM, which shows high rate of return to sports in athletes, 89% with the Oates treatment compared to 51%. And this is good for the small to medium sized lesions, because you are getting closer to the hyaline type. So the longevity is good. Now, in India, we do have the gel based ACI, which is good for medium to large size defects. There is an ease of harvesting. You can do it arthroscopically. But really, what kind of concerns me in my practice is that you're taking a biopsy from a non-weight bearing area. You're relying on dedifferentiation. you're taking it to the lab. There is a month of processing involved. So, cellular senescence is a concern. And, earlier there was some kind of delay in getting the approval. So, it's come back, but that remains a concern. And my major handicap is the two-stage procedure. So there is a cost and a readmission involved. But ACI, worldwide has shown very good survivorship at 10 years with a higher return to function. And also, if you compare it to some form of marrow venting, it is definitely doing very well. So, my go-to option for medium to large defects over the years has been a single stage procedure. So up until a couple of years ago, BMAC was my procedure of choice, being a single stage, ease of harvesting, and we are all aware of the anabolic effects of chondrocytes on growth factors and the anti-inflammatory effects. So it's a easy procedure and can be done as a single stage. And we can do it arthroscopically, but if you see my images on the right, when it comes to patella, I do it mini open because I want to make sure that I can approach the defect and do a good job. The only kind of limitation of BMAC procedure would be the influence of the host condition. So, you are harvesting the cells from the posterior crest. So, you need to healthy cells. But again, in my practice over the years, I've seen that it's not much of a concern. Now, BMAC has shown very good results. You can see these two papers where at 5-year follow-ups for ICRS grade 3 and 4 lesions, it has shown good results. And also, if you have a multiple lesions, again, it did not affect the outcome. So this is a very good single stage option. And this is a patient I did a couple of years ago on the left. That was the arthroscopic image at the end of the procedure, and you can see the nice regenerate. I'd done a second look for some meniscal pathology, and really it was nice and reassuring to see that this nice hyaline like cartilage was formed. So, when we deal these medium and large type defects, really we should aim for hyaline like tissue because it is very close in terms of its stiffness. So in the present day, in the last 2-3 years, I have moved on to what is called as the particulate autologous mince cartilage autocard procedure. Again, single stage, you can replace the chondrocytes, introduce them in a nice healthy matrix, and then you can kind of deposit them or harvest them and give it to the donor side. The only concern is that how much particulate chondrocytes are required for a certain size of defect is not very clear. The procedure is still evolving, but it seems to be doing well. And just to give you an overview, it is referred to as the healing triad, where you are the regenerative cells at the bottom right, you have the matrix, and then the growth factor, which is the PRP. So the regenerative cells are your chondrocytes. So when you are stabilizing the lesion, you are going to do the repair. You harvest that, and you don't kind of suck away and dispose it off, which we conventionally used to do. So you are using those cells. You are kind of mixing it with PRP, and we all know the several advantages of PRP. And then you have a glue. Now, what is recommended for this type of procedure is you don't use a thermal glue like fibrin. So what you use is a thrombinator, which is a mixture of PRP and the thrombin which you use. So, in the cascade, the PRP acts to convert the fibrinogen into fibrin, and that gives rise to a nice cross-linked fibrin clot. And that really helps in this procedure. So if you're doing this type of procedure, all you need is a very low profile shaver blade, a 3mm one. You don't want an aggressive shaver blade because remember, you want to save the chondrocytes. You don't want to damage them. You need a harvester, which is called a graft net. So what it is essentially you connect the white part to the suction device, and it has a filter here. So whatever the fluid is will go through and go into your suction machine, but the filter will harvest all the chondrocytes. So you can you'll have to do multiple suctions so that you empty the graft net, then you again try and get the few more chondrocytes by debriding the peripheral lesion. So that's what you do. You need your PRP machine, and this is the thrombinator where you mix it with the patient's PRP, and it gives a nice glue which will allow us to adhere. So this is a lady who had a mechanical problem, medium-sized defect. So when you see it, front on you see this, but when you flex the knee, you can see that it's quite a large defect in the weight bearing area. Again, all these patients are worked up in terms of alignment, ligament assessment, and meniscal pathology. So, this is a solitary cartilage lesion. So I'll just show you a video of what we do in terms of the AutoCAD procedure. So after we've can you see the video? Or is it?
Video is not visible, so video is not visible.
Okay, just 1 second. Huh? Don't know what's just 1 second. Yeah. Now can you see it now?
Yes, sir, it is visible. Yes.
So I am kind of reaching the lesion, and I am with my ring curate. I'm trying to stabilize the periphery to create a nice edge for my repair, solution to hold on. And with this low profile suction, I am sucking off the chondrocytes from the periphery, and then I used something from the spine instrument like a patty to dry it, and can be done under carbon monoxide or air in dry arthroscopy, where I have sucked off all the fluid and I mixed it with PRP in the back table, and this is the delivery device arthroscopically where I am delivering this nice chondrocytes pasted in the glue. And the best thing to do is you start from proximal, you come to the middle, and then you go to the lower half, and then you align it as you can see here. So after this, we put in the thrombinator, which is the glue, and you wait for around 2 minutes for it to set in. Unlike the Ticel, which sets in fast, this sometimes takes time, so you got to be patient, and then you just gently cycle the knee through a range of motion, and it's holding on. And at the end of the procedure, the PPP, which is the platelet poor plasma, you can just inject it within the joint. So that is the AutoCAD procedure, and this is a patient at 1 year follow-up. So we assess them both radiographically and also in MRI, and we also obviously look for whether they are symptomatic. But this patient at 1 year remains asymptomatic. Again, all the alignments were good, and this is the MRI. So what our radiologist says that this type of regenerate, which you can see here, is a nice hyaline-like tissue. And that seems to have been a good result. So this is another patient where we have done it at 1 year follow-up. You can see the the cartilage repair tissue both on the front and the sagittal view here. And the radiologist has reported this with a MOCART score as high as 85. So all this grading is done independently, because we send them to our radiologists and we want them to give us an honest idea, so we know whether or not to continue using this technique or whether to move on to something as an alternative. So this is quite good, and obviously the literature is coming out with a lot of results midterm, wherein this procedure seems to be doing well, and it involves the standard post-operative care where depending on the size of the lesion, you either allow partial or non-weight bearing. You make sure that you don't patellofemoral lesions, you don't want them to flex beyond 90 earlier than 6 weeks, and return to sporting activities typically after 6 months. For the very large defects, we have certain banks in our country where we have no option but to use these osteochondral allografts. But fortunately, the incidence of these large defects is less. Most of the time, if you have these large defects and if they present early, you want to fix them with like an OCD. So that is good. But however, a final word on the management of the active professional athletes, because they are a different breed compared to our sedentary weekend warriors. So if you see these patients within their career, you want to do less is more. So even for the medium-sized defects, you want to try and debride the lesion if required, maybe do a micro drilling and get them back to their activity. Because if you do some sort of a ACI or a BMAC or an AutoCAD type of procedure, they are going to have a long rehab and perhaps it could be career ending. So for professional athletes, generally just chondroplasty and maybe maximum bone marrow stimulation at the end of the career, they need to be counseled that they would need some sort of a major cartilage repair type of technique. So that probably concludes my talk. I thank you all for your attention, and I take this opportunity to invite you to the Arthroni meeting in Mumbai, which I am hosting next year. Thank you very much for your attention. I'll stop sharing my screen.
Thank you so much, sir. Thank you for a wonderful lecture. I welcome Dr. Rajat Jangir, sir, President of ICS, to the webinar. And sir, one question, sir. Sir, how important is scanogram in your clinical practice? How often you go for scanogram?
So for my cartilage surgeries, I will routinely do the scanogram. So, it is a must for me. Even in my, I mean, since we are talking about scanogram, all the patients who present with meniscus root tears, I definitely get a scanogram because I need to check whether or not I need to correct the alignment simultaneously.
Okay. And sir, what is your non-operative management line? So apart from painkillers, what do you give? What drugs you give?
So I'm not right. So again, visco supplementation, glucosamine, chondroitin, but I am very honest with them that the efficacy is questionable. So I just rely more on exercises, strengthening exercises, avoid squats, avoid stairs, and if at all they come and ask me for PRP or some hyaluronic acid, unless they really convince me to give it to them, I have a very high threshold to do this because I strongly feel against it. But having said that, maybe somebody who's athletic and wants to get back to playing, is aware that this may give a short-term benefit. I wouldn't hesitate injecting hyaluronic acid or a PRP injection.
So for patients, like if they're non athlete and if they're like around 40 to 50 years old or more than 50 years old, so if patient they have a small defect like around 2 centimeter square defect is there. So do you do debridement chondroplasty, or you go for micro drilling, or you do something, you add BMAC with that? So what is your take on patients who are more than 40 years of age and we find them having a small defect?
Right. So generally, I would encounter these patients in two scenarios. One is an incidental finding when I'm doing a ligament, like an ACL type of surgery, or a root repair type, for example, in that age group. The second would be an isolated, problem wherein the patient just has the cartilage-related issue. Now, again, if it's less than 2 centimeters, I will just stick to the micro drilling. I will not do a lot, but having said that, and especially the incidental ones where I'm doing a ligament procedure. But if a patient has a solitary cartilage related pathology and they've come to seek treatment, two and a half, I would then think of doing just a chondral lesion. I would do an autocart. If it is osteochondral, then I would think about an Oates procedure for that size of a lesion.
Even for the smaller defect, you can go for Oates. You think for Oates.
I would say less than to avoid. So 1.5 would be good for micro drilling, 1.5 and below. Maybe slightly higher between the 1.5 and 2.5. An Oates or an autocart or a BMAC would be a good option.
Okay. So, and have you opted for nano drilling these days, because nano drilling has
Correct.
come.
So when I'm talking about micro drilling, I refer to the same. Basically,
Okay.
that's what it means, that you drill multiple holes. Now, one thing which I would just add to the AutoCAD option is that in the first generation of AutoCAD treatment, they used to do this micro drilling or nano drilling and then put the AutoCAD cartilage repair solution. But they found that that does not give a good regenerate. So as you saw in my video, we don't do any nano drilling before we deliver the AutoCAD paste. We just deliver it to the virgin chondral area.
Okay. And sir, what is your basic rehabilitation protocol in sports athletes who are having medium defects?
Right. So again, as I mentioned, there would be chondroplasty or maybe nano drilling. So, maybe 15, 20 days of just a bit of rest and gradual return to activities, get them to strengthen the knee. So they would return as early as 6 to 8 weeks by just chondroplasty or nano drilling. Whereas if you end up doing some sort of a cartilage repair, then at least 3 to 4 months before you allow them. But avoid any impact type of activities for at least 6 months.
If we have done only micro drilling or only debridement chondroplasty, then can we, how fast we can make the sports player return to his previous level of play?
So again, I would be looking at a defect which is less than 1.5 centimeters square. So yeah, as I said, around 8 weeks or maximum. So see, so what we look for is the patient loading pain free. What we look for, is there any effusion still there? Is there any tenderness? So these are the clinical signs which would help me decide whether to allow them to return at 8 weeks or 12 weeks, for example.
Okay. And sir, what is your protocol for next MRI post-op?
Right. So for the micro drillings, unless they are symptomatic, and generally they tend to be at 2 years plus. I would not do. I would do MRI academically for these BMAC and these AutoCAD procedures, because I want to make sure that if a procedure is being advised, whether it's standing the test of time. So I would do them every at 1 year, 2 years, and then maybe at 5 years, unless the patient comes back to me earlier with some symptoms, when then I would go back and see whether there is some failure of part or the entire repair area.
Okay, sir. And so one last question. What is the role of MRI cardiogram in your scenarios, in your practice?
Correct. So when I used to send patients for MRI in relation to cartilage issues, I used to tell my radiologist do a cardiogram, but they came to me saying that the 3 Tesla MRI is quite a high resolution. So whatever information I need or equivalent to a cardiogram, they are able to provide it to me. So so I would leave it to the radiologist to take a call whether or not. I just give them the clinical information, and then they would decide whether or not cardiogram is required, because there is an added cost. So unless they would add to the reporting and information,
Right.
I will not insist on that.
Okay. So thank you so much, sir. Any questions from the panelists? And if they're not, thank you so much, sir, for your talk on this. And we learned a lot. And next, I invite Dr. Karthik to introduce Dr. Jyoti Prasant. And we have a case presentation followed by this. Thank you so much, sir.
Thank you.
Yeah, good evening. I would like to introduce Dr. Joshi Prasad now, who will be taking a case presentation. So he's a senior orthopedic consultant and head of Department of Orthopedics of Baby Memorial Hospital in Kannur. He has more than 10 years of experience in dealing with arthroscopic surgeries and sports surgeries and joint replacement. He's also an expertise in trauma care and minimally invasive surgeries. He is also a known editor of Kerala Journal of Orthopedics, and he has many memberships under him. So he's also 40 plus peer-reviewed publications and is a regular faculty and moderator in many nationals and international conferences. So, sir, I would like you to take over the screen and please
Yeah,
share your
thank you.
results.
Yeah. Can I share the presentation? Am I audible now?
You are audible, sir. Yes, you can share.
Okay. I'll just deal with a few cases in which the cartilage injuries I will describe with in which I fixed with biopinch. Okay, so it is osteochondral injuries. Am I audible now? My screen is visible.
Yes, sir, it's visible and your screen is visible.
Is my screen visible? Yeah, okay. So already my previous speaker has mentioned many things, so I'll just deal with the nano fracture. This is a video of the nano fracture. You can see that the nano drilling is being
You
done.
do it slide. Ah, yes.
Yeah. Now you can see the nano drilling being done over there. The video, is it visible now? Is the video
Video is
visible?
visible. Yes.
So you are using that all suture angle drill sleeve, and you are drilling with 1 mm K wire. So you can use it a very useful technique for nano drilling. Here you can see that, and the cartilage defect is being drilled over there. So it's the first case I will deal with. It's a 16-year-old dancer who came with a left knee injury during dance, and this MRI revealed osteochondral fracture. So this is a fracture. It's a posterior aspect of the knee. How will you deal with this? That's my question. Dr. Soumya, what's your opinion? Hello?
Yes. So it's a osteochondral fracture of the so lateral articular surface. So it's a non-weight bearing surface of the yes. So Do you have X-ray of this? 3D
Yeah,
CT.
actually, the X-ray, I'll come to it. I don't have an X-ray for it. So we
So,
went
so
for a
first of all, it
posterior.
needs to be fixed. It needs to be
Yeah,
fixed.
of course. Yeah. So how we fixed it is we'll deal with it. That is osteochondral defect we fixed with biodegradable compression screws and biopins. Okay. We went through the posterior approach and fixed it this way. And so I will just deal with how we can fix these kind of fractures with biopins and biodegradable cable. I have three or four cases which we will discuss. And this is a post-operative 3D distal femur articular surface which showing very nicely. It is sitting there. You can see the 3D CT over there. And this is a 6 month follow-up, and it is very much integrated, and the functionality is very good. And the second case, I will just discuss a 12-year-old girl with the elbow fracture of the capitulum. You can see that there's a small fracture over there, and AP and lateral X-rays are visible over here. This also we dealt with took a CT scan, and we found that this is a fracture. And we reduced and fixed it with initially KVS, and then you put the biodegradable fluoride. So here you can see the fluoroscopy reduction with KVS. And these are the surgical steps that one should be very much careful about while reducing it. Okay. The first one is to measure the size, reduce it and fix it professionally with KVS. And then we should measure exactly how much the fragment is, and there is a K-wire which has got incremental marking over it, which will be available with the biodegradable K-wires. So you can measure the K-wires. That's a step 2, and these K-wires should be perpendicular to the fracture. And the step 3 is we have a sleeve on the top in which you can keep the K-wires, matured K-wires, and you can remove it and put the biodegradable K-wires. So these are the 4 steps which you should take care of. That is, while first you should reduce it, you should fix it with a normal K-wire. You should remove the normal K-wires and put the graded K-wires. And with the graded K-wires, you know exactly how much length of the biodegradable K-wire is needed. And after that, you should put the biodegradable K-wire, and you can cut the blunt end, and you can use both the ends. So in this way, after you are putting it, you have a cylindrical sleeve in which you are malleting the blunt area, and it goes and sits there. And the cut area is flattened so that it stays below the articular surface, just below the cartilage. So these are the surgical steps which should take care while putting this osteochondral fracture back into place. So this is a post-op X-ray. An MRI also you can see the 100% healing, and the function is came back. The case number 3 is another one in which a girl with a small twisting injury, with osteochondral injury in the knee joint. You can see the patella underneath the patella is gone. 16 into 4 millimeter injury is there, and subchondral injury is there. So we fixed the same way as we fixed the capitulum, biodegradable K-wires. That is, you can see that picture. You can see 3 K-wires over there, and this patient also has a very good result. The MRI is taken after 6 months follow-up. And the case 4, a similar case in which a patella, another osteochondral injury has occurred there. Exactly the same mechanism. We again fixed it with the same bio-K-wire. And here we used some vicral sutures also. We took it across the other side of the patella and tied it for the support of the bio-K-wire. You can see that the vicral wires are also there. And this is 6 months follow-up, and with complete range of movement. Another case is the person who came with alleged for tibia, everything. And this was an image of the osteochondral injury with the CT scan. It was just outside, not at the trochlea, but just outside it. So we did it with this intra picture. You can see that the flap of cartilage has been elevated, osteochondral fragment has been elevated. So what we did here is that we fixed with 2 anchors. We used 2 all suture anchors to fix it. Here you can see, you have put 2 all suture anchors, the anchor to fix it, less like a V. So this is an innovative way in which we fix this osteochondral injury. So I just wanted to share the experience of this osteochondral fracture fixation with these few cases. And I'd like to invite you all to Kannur for IAS 1 conference on May 10th. Thank you so much for your patient listening. Thank you.
Okay. Thank you, Dr. Jyoti Prasad. One question. Have you just as you have shown case number 4 in this,
Yeah.
where you fixed the patella, the osteochondral fracture fragment in the patella. So
Yeah.
have you any experience with the vicryl sutures, or there's a device known as a DG lock which has come?
Yeah. From Ceronics. Yeah. A new one from Ceronics.
Yeah. So it is after
Yeah.
Dr.
So
Deepak, sir. Yes. So
yeah,
have you
yeah,
any?
yeah. No, I have
Yeah.
no experience on that because in the patella I tried Vicryl only because in just like a British track configuration, you can drill through and tie it on the other surface of the patella. So I found it is very supportive, and this was
So you use only biodegradable pens,
an additional support to the biocavers that we put.
any use
Huh?
of BMAC, or any use of PRP with
No,
after
I never.
biodegradable pens?
No, I never did anything like that. With the biocavers, it gave a solid fixation. After that, the patient was mobilized, and as I showed, got almost nearly full functionality after that.
Okay.
I didn't use any PRP or BMAC.
Okay. And any case of any complication, like the biopens have come out or anything? Have you ever seen that?
No, I have an experience of almost 10 to 15 cases in which one or two cases had an initial synovitis, but later on it settled down. So it didn't have any major complications still.
Okay. Okay. And Dr. Shreyas, sir, any question
Actually,
to Dr. Jyoti Prasad?
it's an osteochondral defect. So
What JP has highlighted is very important, that if you have a traumatic and you have a piece which you can match, even if it's a few weeks down the line, you should try and fix it, because you will get hyaline like cartilage. Sometimes if you have a small comminuted area which is missing, then maybe you can supplement it with micro drilling or nano drilling, so that at least that small area of regenerate happens. But wherever possible, if we can just reattach the fragments, that is the best way to kind of do the cartilage repair.
Yes, sir. Even the surface area is weight bearing or not, we have to fix the fracture. That is the message. Yes, sir. Okay. So, any other question from the panelists? So, all the cases were very nicely shown by Dr. Jyoti Prasad sir, and we had an excellent talk by Dr. Shreyas Vijay sir. And if there is no question, if is there any question, Dr. Karthik, from the viewers?
No, sir.
No, sir. So then I would like to take this opportunity to end this webinar. And thank you so much, Dr. Shreyas sir, for joining us, and Dr. Jyoti Prasad for joining us and sharing valuable insights. And thank you, everyone, for joining us. Thank you so much. Thank you
Yeah,
so much.
thank you very much. It was a pleasure being here, and congratulations on this initiative.
thank you so much.
Thank you so much.
Bye. Bye bye.
Thank you, sir.
Okay, thank you. Thank you, Dr. Karthik.
Thank you very